So below the knee angioplasty is challenging in a couple ways. First, the below the knee vessels are smaller. Usually we're ranging between 2 and 4 millimeters. Second, the pathology of the lesions are a little bit different than the rest of the leg. Typically we encounter calcium, specifically medial calcium as well as intimal calcium. So when we intervene on these vessels, different types of complications occur because of the pathology of plaque and the small vessel size. When we talk about complications below the knee, or adverse events, I guess you would say, it's all revolved around the calcific plaque typically, and the small vessel size. So with plain balloon angioplasty, usually we'll get dissections, and commonly they're spiral dissections because of the calcium, and also recoil. Remember, there was a study by Bowman and Baumgartner that was published, and what they showed was if they waited 15 minutes, there was a significant group after endovascular intervention, balloon angioplasty, that has significant recoil. And the reason that is, we believe, is probably because of that medial calcium. It's not affected, we haven't adequately prepped the vessel, so over time the vessel compresses back. So I've used the S4 device, the Shockwave S4, below the knee and have had great outcomes. Again, when you use this device, you go to low pressure. So you blow a balloon up so it's opposed to the vessel wall, so you don't get barotrauma, and then you let the device work with the ultrasonic waves. And ultimately what it does is it causes microfissures in the intima, in the media of these vessels. There was an eloquent study, it was a sub-study that Andrew Holden looked at where he used OCT below the knee and showed that these microfissures actually extended past the intima, and we believe into the media. So ultimately, you don't get that vessel recoil and you don't get that spiral dissection. A lot of times when we're using this below the knee is for critical limb ischemia, is to improve blood flow to a wound so it'll heal, ultimately decreasing morbidity and mortality. The issue is patency. A lot of times you get recoil, you get restenosis, so you have to go back in and reopen the vessel multiple times before the wound is ultimately healed. With IVL, or intravascular lithotripsy, what it does is it helps prevent that recoil. It also helps prevent restenosis, because if we're able to crack that calcium, ultimately we're able to deliver a biologic to get to the advent tissue to prevent that smooth muscle cell proliferation and ultimately restenosis.